Hi, I'm Duncan Ferguson. In this unit we're going to move on from having screened a dog for hypothyroidism to have some questionable results. For instance, T4 might be low and we need to understand this better, so we're going to go on to confirmation tests, and we're going to focus our attention on free T4 and also on TSH and the combinations of those with T4 and TSH as well as free T4 and TSH. I'd like to again give credit to the group in 2003 that was requested by the Society for Comparative Endocrinology to take a look at the current data, the data at the time for thyroid function testing in the dog, and come up with some consensus recommendations. And many of the things I'm going to tell you in this unit come from that discussion. So the acronyms again, we've talked about them before and you can review these. I'm going to be trying to spell them out as I go through each slide. So let's talk about free T4. First of all, it's important to note that free T4 is the unbound fraction of hormone, and it's generally about 0.1% in dogs and cats. So we're going to focus on dogs and cats. It's the single test, when measured alone, that has the highest diagnostic sensitivity, specificity, and accuracy. Remember, those are the three criteria we judge a test for. So as a single test, this would be extremely good to measure whenever possible, because in addition it correlates well with the clinical status, whether the animal's hypothyroid or hyperthyroid. Now, to the technical aspects, and we'll go into this in the next slide, it's important to recognize that for our domestic animals, measuring the free T4 by dialysis is preferable. The non-dialysis methods tend to be less accurate, and particularly in circumstances that we're most interested, that is, when we have presence of illness or drugs, which can displace thyroid hormone in its binding from serum proteins. In this slide we have a cartoon which I showed you during the thyroid physiology modules that shows how at the top T4 dissociates from its binding proteins, so that's plasma binding proteins, PBP, and becomes free, free form. So this is a reversible reaction that occurs in the plasma, and it makes available free T4 to be able to enter the cell. Of course, it does this through interacting either by diffusion, interacting with receptors that might be on the cell, or transporters that actually can facilitate the entrance of thyroid hormone into the cell. As we've said, it's this free fraction of T4, generally about 0.1% of the total in dogs and cats, which at any moment is biologically active. And so we see that the action is driven by it, as well as the metabolism, and part of that metabolism is deiodination. You might ask, well, what happens with a lipophilic hormone that gets inside of a cell, which is an aqueous environment? Well, again, there's a cytosolic thyroid hormone binding protein that picks it up and actually helps to convey it around and deliver it to the sites necessary within the cell. We've said also that this can be modeled, and that's on the bottom, and this is how we measure it in vitro, by putting serum in a chamber, which is over here. This would be the plasma or serum, and we mimic this process with a semi-permeable membrane. Semi-permeable membrane, which allows only the small molecules, in this case the free T4, to move across. And then this goes in equilibrium and it mimics, in a sense, what's going on in the plasma. You use very sensitive, you can use by our radioimmunoassay, a very sensitive T4 RAA over here, which is the basis of some of the testing, or you can use radioactivity, usually I-125. That's usually for research purposes. And we call the fraction of T4, which moves across the membrane equilibrium, the free T4 fraction. So that if you were to compare the free T4 divided by the total T4, we'd call that fraction, the free T4 fraction, that's the 0.1%, or 1 out of 1,000. And you can see that if there were antibodies to T4 in a dog's serum due to autoimmune thyroiditis, these antibodies would be large proteins, and they would if they're IgG, they would not make it across the membrane, and so it would not lead to a problem with measuring T4 in the dialysate on the right side of that membrane. Total T4 assays are generally disrupted, that is, they provide false results in the presence of these additional antiserums. So measuring free T4 is, in a sense, a very valid thing to consider doing when you believe you have anti-T4 antibodies and you have a false result for the T4 assay. In this slide, we've seen part of this. We've seen the T4 results for diagnostic tests. So now let's compare the free T4 results here on the right side to that with T4. You can see that a valid measurement of free T4 provides greater sensitivity, greater specificity, and greater accuracy. And the main reason is that it is unaffected by the presence of low affinity binding inhibitors that we might see in illness or with drugs, or by the presence of T4 autoantibodies. Free T4 is a single test with the highest diagnostic criteria or value in all categories. And it is certainly recommended when the animal is sick, treated with drugs which interfere with thyroid hormone binding, and in known or suspected situations where there's T4 autoantibodies, when we know that T4 measurement is invalidated. So let's now summarize what we can learn from measuring T4 and free T4. So we know from our last unit that if T4 is normal, we can rule out hypothyroidism in 90% of the cases. If we remove T4 antibodies from the pool, or in other words, we take out those animals that have that, this diagnostic rule out can approach 100%. And now we can say with one test, without knowing anything about T4 autoantibodies, we can get a valid measurement in 98% of the cases with free T4. And therein lies a significant amount of the value for measuring free T4 in routine situations, or in situations where T4 is just not clear or possibly false. In this graph, in this table, we would like to compare the diagnostic value of TSH alone, and then when it's paired with T4, and then when it's paired with free T4. It's often paired with T4 as a routine basis. Free T4 is less commonly paired immediately with TSH, but this is something that in more complicated cases I certainly would recommend. The first thing is to note, as we said before, that TSH is a poor screening test. That is, we're missing somewhere between roughly 15 to 25% of cases. TSH doesn't rise. And even one study showed that it could be as high as 40% of dogs that don't have elevated TSH with otherwise documented hypothyroidism. However, when a low T4 is observed, and you have an increase in TSH, this is a relatively specific and reliable finding. So you can see, while it doesn't do much for the sensitivity, it certainly raises your specificity for the diagnosis up into the mid-90s. and you can see it's even better for free T4. So this follows a general principle of endocrinology when you're trying to define or diagnose a deficit disorder like hypothyroidism, showing the hormone being low, in this case the active hormone even better, free T4, and an elevated pituitary hormone like TSH becomes a very valid piece of evidence for hypothyroidism. So let's focus on TSH. What does it bring to the table? Basically, you can see a high value adds specificity. We showed that in the previous graph, to the observation of a low total T4 or low free T4. But by itself, it's a poor screening test because TSH doesn't rise in a certain proportion of dogs. The reasons we mentioned before are that dogs are different than humans. TSH rises early in disease and maybe falls in chronic disease, and there may be pulsatile release in hypothyroid dogs. But generally this doesn't lead to absolutely low values. The pulsatility in hypothyroid dogs generally still leaves TSH elevated most of the time. So the most important point here is that you want to use TSH in combination with T4 or free T4. One of the complicating factors with trying to make a diagnosis of hypothyroidism in and amongst a lot of other possible diseases are that there are other therapies being employed in that case at the time. And so I wanted to list for you, we can go over them individually, but I wanted to list for you at least some of the more prominent examples of drugs that do appear to influence thyroid function in the dog. The first one that I'd like to mention are glucocorticoids. We know that high doses of and with chronic therapy, high doses usually anywhere above anti-inflammatory doses, 0.5 milligram per kilogram of prednisolone, for example, and higher, you can see the T4 will fall. Free T4 generally stays more constant, and TSH generally, in most studies, has been unchanged. Although we believe that possibly it has fallen, and it's just we're not able to measure it. And so we believe that glucocorticoids have an effect on the pituitary. A more direct thyroid insult, if you will, are the administration of sulfonamides. So trimethoprim sulfa given to a dog, given particularly at high dermatological doses, is actually known to be goitrogenic and will actually cause hypothyroidism, where free T4, T4 fall, TSH elevate. A very common drug that's confounds thyroid function testing is phenobarbital. Particularly with chronic therapy, you can see a mild fall in total T4 and free T4, and TSH in most studies has remained normal. We don't generally think that these animals are hypothyroid. It's complicated because seizuring animals have also been shown to have low thyroid values, and they tend to fall further the more frequently or more recently an animal has had a seizure. So this is important to distinguish. But it's known that phenobarb in animals that are not currently seizuring can depress T4. And it's mainly through stimulating the excretion of T4 through the liver. The other class of drugs that we need to pay attention to are an example of drugs that interfere with binding of thyroid hormone in serum and may also do this within the cell. We know that carprofen, Rimadyl, will have lower T4 and TSH, whereas free T4 stays normal. Here's another general lesson. When we have drugs, particularly those that interfere with binding in the serum, then think about measuring free T4 by dialysis. Clomipramine is another drug that's been studied, and we'll see here a mild fall in total T4 and free T4 where TSH remains normal, suggesting that in this case it is not a hypothyroid condition. Most of these drugs, other than sulfonamides, do not actually cause hypothyroidism. by our best definitions. So what have we learned in this unit? We've learned that free T4 by equilibrium dialysis is the single test with the highest diagnostic sensitivity, specificity, and accuracy, all in the mid-90s. I would note that measuring free T4 by dialysis is preferred in domestic animals, most of our domestic animals, because the assays that are non-dialysis methods are generally designed for human serum, which has high levels of thyroxine binding globulin. And therefore, when you use a non-dialysis method or have a laboratory that uses one, there should be some validation of this method against free T4 by dialysis as a gold standard. And what I mean by that is that not only should hypothyroid and euthyroid dogs, for example, be measured, but also animals with sickness and animals with drugs. And so this gets to the second point, which is that anytime you have conditions where there's non-thyroidal illness or the presence of drugs that interfere with thyroid hormone binding, like NSAIDs, or the presence of T4 autoantibodies, these are the actual conditions where free T4 shines, and it only shines in the dialysis method. These are the situations which are very difficult to validate other techniques for measuring free T4 against. And finally, we learned that TSH measurement is a poor screening test by itself, but a high TSH value adds considerable specificity, that's the key word, for hypothyroidism when there's a low T4 or free T4 measured concurrently.